Thanks, Doug. And I wanted to thank Holly and Truman Katz for having me back. It's really wonderful to be here. And I know that this is a topic that's really close to Holly's heart, so it's a special honor to be here and to be part of this. And I apologize for bringing the British weather with me. I was looking forward to the Seattle summer. I'm very sorry about that. So as Doug said, most of my work focuses on thinking about the practical ethical barriers to providing better health care for kids who are on their own. And so today I'm going to talk about, following on what Steve said and a lot of what Catherine just said, a group of kids who are invisible. And it's, I think, an exciting opportunity, given who's here in this room, to think about today the role of advocacy for those kids who continue to be really left out of all of the successes and the exciting interventions and increased creative support that's now available for those living with autism, and to think fairly critically about what can we do differently for a group of kids who may not have advocates in their lives. So which kids am I talking about? The range of kids, even in countries like the US, who are on their own in various respects. They may have adults that come in and out of their lives, but for various circumstances and reasons, they don't have parents. They don't even have a single parent to care for them, to advocate them, to notice their behavior when they're young, bring them into hospital. And there are a range of sort of official categories of these kids. So there are children who may have lost both parents due to illness, due to accident. They may have lost their parents or come out of their home or been taken out of their home due to socioeconomic challenges. And this is increasingly the kinds of kids that we're seeing in the UK and in Europe and here as well, are kids that are taken out of their homes or separated from parents due to upheaval or conflict. So we're seeing a lot of kids who are sent ahead from Syria, from North Africa, who are coming into the children's hospitals in London and throughout England, and they're unaccompanied, and they range in age from 8 to 18. So there are a lot of reasons why children might not be with parents, might not have a stable home. Here at Children's, we saw quite a number of kids who were in foster care, and oftentimes foster care is not a very stable situation. The kids will go from one temporary placement to another. So what we're going to reflect on for the next 30 minutes or so is how children within this category of kids and teenagers deal with and live with autism, and how can we do better by them? What are some of the special challenges that face them? So I'm going to share two patient stories with you. One is from the US and one is from one of our hospitals in the UK. So the first story is of Lisa, a young girl named Lisa. I've changed the details to protect their privacy. Lisa is a 7-year-old girl who was removed from her home at age 5 after having been found several times wandering alone outside her home. On the day of her removal, she was found walking alone in traffic in the middle of the night. It was quickly obvious to the child welfare staff that Lisa had developmental delays, including very limited speech, unusual social interaction, and tantruming behaviors. These had not been evaluated previously. She was brought in for evaluation by a developmental behavioral pediatrician, which is unusual to have that level of expertise. And when she was brought in for evaluation, she was diagnosed with autism spectrum disorder. She was shortly thereafter, in the course of going through care, placed in a group home, and referrals for services were made and increased school-based support by the child welfare workers that were assigned to her case. She soon showed some improvement in her speech and her social interaction and her ability to cope with day-to-day in school transportation. But shortly after that, she was placed into a foster home, which is a good thing for kids like this, to go from the group home to a foster home. But for a child like Lisa, you can imagine how distressful that was, to go from a stable situation relatively to a new situation that was quite dramatically different. New people, new siblings, new home environment, new route to school. And when that happened, her symptoms became worsened again, and she had a number of outbursts and things that started to jeopardize her transportation for school. They were concerned that it was too disruptive to the other kids. So the pediatrician that was involved initially in the diagnosis was really worried that if not treated or supported better, that she risked losing her transportation to school and thereby losing the ability to continue to attend school. So just to give you a picture of what it's like to navigate the healthcare system, even when you are a pediatrician, Catherine talked about some of the challenges when you're a parent. This pediatrician was a real advocate for Lisa and tried to coax and cajole the caseworkers to get the appropriate care and support in place to make sure that Lisa had somebody to accompany her to school, and to try to advocate for some changes in the school setting to make it easier for her to cope, as well as looking at the foster home situation. How could things be done better? How could these parents be helped? But one of the issues that the pediatrician ran into was that the law was not exactly on her side. So she thought that offering some medication to help with her behaviors during this rough patch might be supportive and help sort of ameliorate some of the spikes in her behavior in situations that she found challenging. But in order to do so, she had to have consent from the biological parents, or she had to have a court order from basically relinquishing the need for the parents' consent. And that was refused. And what had happened in the meantime was that the social worker had changed on the case, so she had been reassigned. The new social worker said, I'm really uncomfortable pushing an order through for medication for a child that I don't know well. And in fact, I can't do it because she's not my case, right? She's not my patient. So the pediatrician had to try to, again, this took weeks to navigate and find who is the advocate for Lisa now, who's the one who can make these decisions. And she met with repeated barriers and stalling or no return calls. So this odyssey happened, the odyssey that a lot of parents go through, and a lot of parents are the ones that are on the phone and fighting for the patient. In this case, it was a pediatrician. She started to worry that Lisa was at imminent risk of harm, was not at imminent risk of harm, but that she was suffering really serious setbacks. And the law was set up in such a way that you can only get legal support to make these decisions if you were at imminent risk of harm to yourself or others, which she wasn't. So in short, 3 months had passed, and she still hadn't received approval to offer the medication for Lisa. And there was still no response from child welfare. These caseworkers often have 30, 40 kids assigned to them, and this particular caseworker hadn't gotten back to the pediatrician. So I'll leave it there, and I'll come back to her story at the end. The second patient I'll call Tommy. Tommy is a 12-year-old in the UK in state care. He was diagnosed with ASD, also by a pediatrician after being brought in by a caseworker. His biological parents, in this case, voluntarily placed him in foster care, and they maintained full parental rights after they basically were really struggling with trying to care for him day to day in the home. They had 3 siblings, one of which was a special needs child, and they just found it too difficult to cope. The mother had rheumatoid arthritis, and the father struggled with clinical depression. So they loved their child very much, but they gave him up and placed him in foster home because they just felt that they couldn't give him the care and support that he needed. He went through 7 foster placements in the course of 2 years, which is really astonishing. Usually because of some of the challenges that the foster parents faced in just supporting and mitigating the triggers for his behavior. In his most recent foster placement, it came to an end when he was verbally abusive and striking out at some of the other siblings in the household, and even threatened one of the parents, foster mom, with a knife. And when you look back at the reasons and what led up to that, what precipitated that behavior, they had gone out basically on date night and hadn't let him know that it was out of their ordinary family routine. And so both the mother and father went out that night and didn't tell him, and he became frightened and lashed out. And when the mom came home, he was angry, and he had been in the kitchen, and he picked up the knife and threatened her. So he lost that placement and again was placed in state care in a group home. So each move that Tommy made meant new parents, new home, new route to school, new NHS clinic, new everything. And so all of the triggers and the types of situations that can be very challenging for anyone living with autism were exacerbated and especially difficult for Tommy. So I give you these two stories just to get you thinking, I think, in a personal way about kids like this who have a variety of needs. Again, to underscore something that Steve said, we're talking about a lifetime of support that's needed, and a lifetime of encouragement, and a lifetime of really understanding what leads to fulfillment and well-being for somebody who's living with autism. So when you think about the stories of Lisa and Tommy, where are the gaps? Where did we not do right by them? Where could we improve our support? And it's important to think about, I think, the developmental spectrum, and to notice really at each stage along the way, something was dropped, or there was a barrier to access to treatment, or to expertise, or to somebody advocating for these children and teenagers. So it starts with diagnosis at the outset. And as Catherine said, it's the parents who are noticing behaviors. It's the parents who are bringing the child in. You saw her complicated graph of what has to be navigated in the health system, and it's parents who are taking the child through all of that. So at the first stage with diagnosis and timely diagnosis, we know that that's really critical for improved functioning, and that's not happening with these kids. And then on into the middle childhood years and adolescence, encouraging peer support and social interaction in a supportive way is really critical. And these are kids who are on their own, or they're in group homes. They have a very unpredictable peer group, if they even have a peer group. And so there needs to be a lot more sort of flexibility for these children in recognizing what their particular needs are during adolescence. The transitional years, which you'll hear much more about later, are really critical for teens on their own, or teens who are homeless or living on the street and living on the spectrum. 1 in 3 young adults with autism have no paid job experience 7 years after graduating from high school. So you can imagine, again, when you layer this on top of the challenges that kids on their own already face, it can be really difficult to try to help them with transition to a job, keeping a job, going to vocational training. Now, these are challenges that we know really well at Orion Center, for example, here in Seattle. They're wonderful vocational programs that get kids off the street and transition them to self-dependent living, to holding a job, to going to school. And yet we don't really have those supports in place for kids who are on their own, who have developmental challenges, or who are on the spectrum and need special supports and special interventions to try to make those transitions to adulthood. So when we look at this spectrum and we think about what's missing, I want to encourage you to think about who's missing. I really do think this is about, in part it's about services, but we could have the best services in the world, as we do here, and if you don't have somebody to fight for you, you're not going to have access to those services. So at the heart of this issue of unaccompanied children on the spectrum, I think, is social support, and really thinking how we can be creative about social support when families are not intact or when parents are absent. So on the flip side, when you think about young adults and adults living with autism who are remarkable, making remarkable contributions to their peer groups, to their society, to their friends, have rich lives, you see behind them oftentimes parents and families and advocates. And so most of the accounts that you'll hear from the activist communities you have to see sort of who's behind them and who's supporting them and who's been fighting for them. They all have, almost all have people who have stood up for them, people who have fought for them, people who, as Steve said, looked and saw a human being and not a disease or a disorder. So what about kids who don't have that? I've thought a bit about how in pediatric care we think about the ethics of care for children and the degree to which in pediatrics we really take parents for granted. And this is something that it's a real blind spot. Again, families are not often perfect. They're not often intact. We have divorced parents. We have single parents. But we've not thought enough about the case of these kids who really are truly on their own, or who have a range of different adults who come in and out of their lives, none of whom are there reliably. So how do we think about this in ethics in terms of what our obligations are when there aren't parents? And how do we replicate these roles that I think we really take for granted? And in particular, the emotional bonds. So you can have, and I've met phenomenal caseworkers and social workers, and they really go above and beyond in what they do for the kids that they care for. But no matter how well-meaning you are, when you are responsible for 30 homeless kids or 30 foster children or kids in juvenile detention, and you've got to have that kind of intimate one-on-one support, help them navigate a new route to school, etc. All of these very time-intensive things, I think love, affection, and unquestioningly having a kid that you would fight for, all the parents in this room, and I know Holly is one of them, you fight for your kids. How many times have you gone to school meetings and shaken them down to try to get them to give you what your child needs in the classroom? So this is just to ask a provocative question, which is, what do we take for granted when we think about the ethics of care in pediatrics for kids who don't have that support in place, and what's at stake? So I want to shift now and think about what's at stake, and how we can sort of appreciate that a delayed ASD diagnosis for children on their own occurs against a backdrop of really a fairly complex series of both social and medical challenges for these kids, in part because of their social circumstances, oftentimes their living conditions, and these get layered on top of each other, and so you often have some conflation of the diagnosis of ASD with other issues that are really quite common with kids who have gone through the kind of stress that a child on their own might be going through. So just a few things to give you a sense of the backdrop and what most pediatricians know about kids on their own. There are really major barriers to access and continuity of care, which is so critical for making the best pathway and supportive pathway for a child or teenager with ASD. They're constantly on the move. They're being shifted around. Their medical record doesn't necessarily travel with them. So it's hard to know who saw them last, what they found out, how they're doing, what their symptoms are. A number of people have reported in qualitative studies that these kids, even when they're teenagers, they often feel judged and lacking the support of parents in the hospital setting. The hospital is a very scary place to be. And they're different, and they feel like the odd one out if they haven't come with their parents in tow. So there are a lot of barriers to these kids just getting to a clinic, even a community outreach clinic. We also know that the physical impact of living on your own or living in transition, as a lot of these kids do, is severe, in particular with largely preventable childhood diseases, so infections, routine childhood infections that go untreated, diabetes and other chronic illnesses that go untreated. But in addition, and I think this is particularly important in thinking about kids on their own with ASD, partly sometimes due to stress and due to living conditions, but a lot of mental illness and PTSD, affective issues just due to having, lack of human contact as an infant or a child. These are all known medical challenges or health challenges of kids who have lived chronically on their own, and particularly teenagers. And so again, you've got the lack of a timely ASD diagnosis, the lack of supportive care layered on top of conditions that are well known that really are exacerbated when you have either a complete lack of a diagnosis of autism or lack of support. And last, I wanted to mention in particular the impact of stress of this kind of life, particularly on a child, and well-known severe stress and PTSD after having lived in a group home, living on the street, even living in foster homes. Again, you can have wonderful foster parents, but going through 7 homes in a year or 2 years is really extraordinary for any child and very, very disruptive. So what we see then with children on their own with ASD is this kind of vicious cycle. Social support, as I said, is critical, and all of you here are a testament to the importance of having advocates and having social support. And so what we see here is that the lack of social support exacerbates the symptoms and behaviors that sometimes attend autism. That then undermines the social support, tenuous as it is, whether it's a foster home placement, whether it's a place on the bus and transportation to school, whether it's a temporary shelter, a transitional apartment, a vocational program. All of these things are in jeopardy for kids who are not supported well enough to then keep these positions of support, if that makes sense. So that's the kind of catch-22 that these kids find themselves in. So the central ethical question I want to pose to you all is to think about kids like Tommy who basically, even though they're not saying this, they're asking who will fight for me. And to think about the roles that all of us play in various aspects, either clinically or in schools or as activists or as writers and historians. What can you do to fight for these kids? Because this is essentially what they're quietly asking. Pediatricians often are the ones on the front lines when you don't have parents on the front lines. People in the community, people in the shelters. There are lots of extraordinary adults that come across the paths of kids who need support and who step up. And they notice, sometimes these are, we're all they have. And just that recognition that somebody else depends on you in that way gets to, I think, the heart of the ethics of thinking about kids without parents. There's a lot of focus in ethics on prevention of harm, on the harm principle. I think that it doesn't get at the heart of our human condition, which is that we're deeply, deeply dependent upon each other. And nowhere is it more pronounced when you think about or meet kids who don't have that luxury, who don't have people necessarily around them to support them. So I think it helps to think instead of the harm principle, instead of what are the best consequences, what do we owe to these kids? I think it's important to ask yourself, who amongst these kids depends on me, and then what are my obligations as a result? There are different roles that people play. So I mentioned there are often a parade of different adults that are involved, and all the success stories, those kids will remember and can point to the people who looked them in the eye and saw a human being and didn't see somebody living on the street. Every single one of them has had those kinds of life-changing encounters. And so these roles are quite varied, from the foster parent to the counselor to the teacher who notices that the child is having challenges in school. There are a lot of different roles that people can play. So back to that developmental pathway, I think at each of these stages, one thing we need to think about are the services that are available. Undeniably, the NHS is struggling with providing adequate services for kids on their own. That's one aspect of this, but I think to think ethically about this, it's not just about services, it's about compassion and it's about time, it's about the commitment that it takes that parents make every single day with kids with autism to fight systems, to challenge systems, to find answers, to be creative. That's what these kids need, and mapped against these different critical points throughout the rest of their lives, not just during childhood. So I want to give you a couple of just practical examples of things that can be done and encourage you to think about how you might step into some of these roles. This is an organization in the UK that supports foster parents for children with special needs. And there's a new training program just focusing on supporting children with autism, setting up your home in a way that's conducive to the way they think and the way they feel, making them more comfortable, doing things like turning off the buzzers on the washer. And these programs are desperately needed to help guide and coach parents through this so that they don't relinquish the child, so that they don't feel overwhelmed. There's another really important approach, which is peer advocacy, and this has been really, really successful in other areas, not just healthcare, for kids on their own and kids coming off the street and migrant youth, and that's peer networks. So a lot of the kids involved in this is an organization called Young Minds, also in the UK. Their focus is on mental illness and also ASD and other issues that teenagers struggle with. And these are teens that have come through sort of on the other end, if you will. And this has been a really successful model for homeless youth and in building networks and basically creating family with each other, noticing that you've gone through this struggle, you've learned important lessons. How can you then return the favor and help somebody else, the next person along? So to close, I think I've reflected a bit about what obligations we have to kids on their own and some of the special challenges with kids with ASD who find themselves in these very challenging social circumstances. And I end with some photos from a really wonderful organization here in Seattle called Youth Care, or Orion Center, some of you know it. And anyone who has worked in an organization like that knows how extraordinary these kids are and what remarkable things they're capable of, having gone through really unbelievable journeys. And I encourage you to think of working with kids like this, particularly kids with autism, as an extraordinary opportunity. So I do think we have an obligation to notice, well, how do they depend on us? But I think it's also really an extraordinary opportunity because they teach us. So I'll end with just a bit of maybe a challenge, and that's to think about, for those of you who are either parents of somebody living with autism or who you yourself are autistic, who has fought for you? Who has helped you get the care that you need? Who's helped find support? For those of you who are pediatricians, clinicians, teachers, activists, who are you fighting for, and how could you share and encourage others to join you in your battles? And I encourage you to think about how you could expand the important activism and work that you do to notice those kids who don't have that family structure or don't have that peer support group, and think about how you can help recreate that for them. Thank you.